Hi guys, Laura Healy, Medonc NP. Just a quick overview on geriatric assessment. Hopefully it's informative. So we're looking at the introduction to geriatric oncology, the domains of comprehensive assessment, the nurse's role, best practice and guidelines, challenges and solutions, and a little bit of a take home. So here we go. As we know, the burden of cancer is in older people is high, and our older generation make up the largest proportion of Australians diagnosed with cancer, and that's 6 in 10 patients. They also make up the majority of living people with cancer and survivors, and those over the age of 60 account for 4 in 5 deaths from cancer. So a quarter of Australians over the age of 85 will have a diagnosis of cancer in their lifetime. So we know they're at a higher risk, but they're also at a little bit more risk of over-treatment or under-treatment when we actually make decisions based solely on a chronological age. So comprehensive geriatric assessment is recommended to inform care, and its time and expertise is feasible for these patients to give them the best possible outcomes. But also there is screening tools available to help identify who would benefit from a more comprehensive in-depth assessment support, and supportive tools and multidisciplinary team involvement. And there is a little bit of lacking consensus on the optimal tool. And we need to be really aware that ageism is a thing in today's society, unfortunately. So we want to do assessments based on geriatric screening to improve their quality of life, their function, and their ability to complete the cancer treatment that we might be offering them. And when this doesn't occur, cancer outcomes are poorer, with increased hospital admissions, length of stay, more toxicities from their therapies, poorer cancer-specific survival, and higher dependency. So, and this is all negatively affecting the healthcare dollar, not only patients' outcomes. So, it's become a major public health concern in developed countries because of our ageing population, as we know, and the increase in cancer incidence with that advanced age. So, our older adults have a diverse. I'll just We know that comprehensive geriatric assessment is required in our patients' population because they have diverse health statuses. They're susceptible to age-related vulnerabilities. We need to understand their diverse individual patient history and any implication that has to their prognosis, the diagnostics that we do to help guide us, treatment decisions, follow-up, and supportive care interventions that they may need. So we do understand that our multidisciplinary and a multidimensional process is required to evaluate our patients' medical, physiological, functional, and social aspects of their care, and also to look at identifying any vulnerabilities, as in frailty, nutritional deficits, mood disorders, cognitive impairment, functional limitations. And the goal is then to avoid that under or over treatment to optimize the quality of life and survival during cancer therapy, and to reduce that risk of ageism. So here are some of the domains that we look at. Sorry, it's a little bit blurry on that bigger screen. So we look at the physical health. So what are their comorbidities? What is their mobility like? Are they at risk of falls? How is their strength? How is their up and go test? Something about something to review to say, can they get up out of the chair independently? It also then helps you formulate what their ECOG is, which is the review of their functional and performance status, helps us guide their suitability for treatment. Again, we look at that functional status. Are they able to perform activities of daily living? What activities can they do? Is it just their self-care, or can they do other activities? We look at their cognition, so we may have to adopt like a mini cognitive assessment or do some other cognitive screening tools if we have concerns. We want to look at their mood and implement any depression scales. like the Global Development Scale. We want to look at their nutrition. Have they lost weight? Is their weight stable? What's their appetite like? And then that also takes you to, do they have dentures, things like that. Really doing that full comprehensive assessment. We really want to look at their medication reviews to make sure there's no polypharmacy. Is there any drug-drug interactions? Can we de-escalate any medication safely? Will there be any interactions with what we are planning to do, give, supply? And then there is a Beers criteria that I'll look at later to talk about polypharmacy. Environmental, are they at home, in their own home? What is it like? Is it up and down stairs? Is it on the flat? Is it single level? Do they have access to support to get them here if they're in an aged care facility and things like that? Because that does not stop us treating them as well. We look at social support, and then we also look at caregiver strain. So do they have family that they're getting looked after, or are they looking after someone? Because that does happen quite substantially in our elder population. And do they have any advanced care planning, and what are their preferences for treatment? Do they actually want treatment? Have we explained it appropriately? Do they understand the implications, the side effects, the toxicities, the appointments and everything else, to actually formulate that informed consent before we go any further? A little bit about screening tools. So in Australia we have multiple, as you can see. They can be implemented at different time points along the trajectory. We have mini mentals, we have the MOCA for us cognitive, we have abbreviated mental test scores, we have the RUDAS and the 5-cog and the dementia scales as well. So they can all be implemented at different time points, as mentioned, depending on what the patient is presenting like and what information we need to gather as the clinician and the treating team to make sure that we are giving them the best optimum care for the best outcome. And then there, as on the screen says, multiple depression screening tools and some medication tools as well to look at polypharmacy and what can we look at stopping, de-escalating, reducing, omitting safely in that grand scheme of things, taking into consideration their background, comorbidities and reason for medications being implemented in the first place. So to look at the nurse in comprehensive geriatric assessment, so I don't think we actually realise how much assessment we actually do on patients all the time. We are consistently reviewing them when they're walking, when they're talking, when they're getting out of the chair, if you're on the ward, when they're showering themselves, if they're able to, if they're not. So we are consistently as nurses reviewing our patients all the time. And we're really good at it. It's something that we do very often. So I think sometimes we don't realise that we're actually doing it, and we're actually really good multitaskers, and we can include that when we're talking to them, when we're administrating medications, or when we're doing treatments in the day treatment centre, or when we've got them up in the shower on the ward and stuff like that. So we're really, really good. And we're also the advocate for our patients as well. So we really advocate for their needs and preferences of them, their families, and we want that reflected in their care decisions. So we're really good at helping them navigate the healthcare system and access resources. So as I said, we advocate. So we normally lead the assessment and advocate for patient-centred care. We communicate our findings not only to the team, but some of us, like cancer care coordinators and nurse practitioners, will present at multidisciplinary team meetings to communicate patients, as we said, ECOG or performance status, fitness for treatment, what they want to do. Do they want to have treatment? Do they want surgery? Do they want a biopsy? Do they want to have radiation? So we are the ones that actually get that information and then relay it to everyone else. Our patients have a lot of follow-up, so we help coordinate that. We facilitate a shared decision-making process by providing the patients with the information and support to make their informed choices. So we're really good at that, and we really help discuss the goals of care. We also do very good assessments, as I've mentioned. Like, we don't actually know we're doing it, but we are actually consistently looking at our patients, assessing them to see, have they improved, have they deteriorated, what's changed, what's different, what's new, and we also escalate that not only to the team but to their family and include them, and we're really good at that communication. We help identify high-risk patients, and we help to implement early appropriate intervention. So is that physio for falls prevention? Do they need a walking aid? Is it the dietitian for nutritional support? They might not be getting enough protein in their diet. Is it that we've got psychosocial issues? Or is it they need social work for my aged care, for some help at home, which could just be Meals on Wheels because they're just not able to do that little bit of their care at home, but other issues. And we also look at our medications when we are reviewing patients as well, and when we're administering the medications to see the appropriateness and the effectiveness as well. So we do that holistic. We also do patient education, so not just for the patients, but we include family and loved ones, that wider family network and support network, or their mob if they're Aboriginal and Torres Strait Islander, so we include all of them within that as well. We are providing support and helping them with coping strategies, so they may decide not to have treatment and then the implications that involves, so it's to help them understand. So they do that informed consent, informed decision making, shared decision making. We also help promote that self-care of themselves, but we also do coordination of care. So we look at what other services do they need referred to, and we do the referrals as well, as it says there, to make sure that they're appropriately and timely followed up, so that nothing gets missed and no one falls through the cracks. This is one of the geriatric screening tools. It's actually on EVIQ. I've just included a little screenshot. This is a cancer specific questionnaire designed for the older cancer patients who may actually benefit from a more comprehensive geriatric assessment. It's got 8 items on it. Assesses various aspects of the patient's well-being to identify patients who may be at an increased risk of frailty or other geriatric related issues that could impact their cancer treatment and outcomes. We look at mobility, food intake, weight loss, neuropsychological status, polypharmacy, self-rated health and age. Simple scoring system, quick assessment for an overall risk, to identify any overall risk. It can actually help us prioritise patients who would benefit from further investigations or more comprehensive screening, and it helps plan treatment and look at outcomes for patients. So patients can do it themselves, or we can do it with them. There is 2 versions. There is a self version as well, and then it can help us look at what referrals do we need to implement, what other supportive services is there that we can access for the patient or refer them on to. This again is the vulnerable elders, again on EVQ. Is a self-reported questionnaire designed to identify patients who may benefit again from that more comprehensive assessment. So 13 questions. The VES 13, it helps to identify our older adults who are more vulnerable and may need more in-depth support or interventions. So it's a function-based scoring system that considers the age of the patient, their self-rated health again, any physical limitations and functional disabilities. It just really helps predict patients who might need more modified treatment plans, and we can also use these in combination with any of the other mini mental scores or depression scores that may be needed if anything's identified by the patient. So the Clinical Oncology Society of Australia have actually advocated for integration of geriatric assessment and management in the Australia Cancer Plan, and this is just a little screenshot of their proposal that they put to the Australian Cancer Plan. So they wanted the principles of respect, value and dignity embedded within the cancer plan to achieve a health equity for older Australians with cancer, to help identify Australians with cancer who would benefit from that further assessment and multidisciplinary care, to help support not only the patient but their carers in optimal cancer care, to build a cancer and aged care workforce with skills and competency to meet the needs of the large number of older Australians with cancer, and establish a national advisory group which would oversee the delivery of cancer care within the plan for Australians, older Australians with cancer, to evaluate key performance indicators and develop an optimal care pathway for treatment of older patients with cancer. So really, what is the challenges to implementing comprehensive geriatric assessment? So it's complex. So challenges are that it's heterogeneous. So that means that our older population are diverse. They have a wide range of health conditions. They have a wide range of cognitive abilities and functional capacity, and it means that we can't apply a one-size-fits-all. It has to be very individualised, which cancer care is becoming very, very individualised. They have multiple coexisting health conditions, can complicate diagnosis and treatment planning. As we've mentioned before, polypharmacy, so it can lead to drug interaction side effects and difficulties with medication management. There is a degree of frailty, not in all of the population, but in some of the population. So we can have decreased physiological reserve. It can impact their health, including their mobility, cognition and nutrition. And there can be limitations with assessment tools, because there's two tools that I've shown you that have been deemed validated and used by EVQ, the Cancer Institute of Australia, but a lot of tools are inadequate. And cognitive impairment as well can be an aspect, not always, but in some instances. So it means it makes it difficult for the patient to fully participate in their assessments and accurately provide information about their health. We have communication barriers, so there can be vision loss, hearing loss, and again, cognitive impairment. That means communication can be limited. We have limited access to interdisciplinary collaboration. We don't have a geriatric oncology service everywhere in Australia. We again have that time constraint in clinic to see patients. Again, implications from communication, and trying to implement a comprehensive geriatric assessment can be challenging, as from the points mentioned above. What can we do to try and fix it or improve it, really? Well, we want to actually do an early implementation for all in the community, not just for cancer patients, but to have a better geriatric assessment. We want to enhance staff competency, so be more aware of the increased needs and requirements of our elderly population and the risk of frailty and what that can entail. We don't have a very good interoperable IT system. It's not transparent across all services, as we still have the issues with trying to go from private to public, GPs to us, etc., back to community. We really just need to start doing it, and as we said previously, COSA are planning for it to be implemented within the cancer plan, so that it's actually part of our screening process. So basically, what are the benefits? So literature has shown that interventions identified from an assessment of our elderly population improves various aspects of the health and well-being, including quality of life, functional status and medication management. It actually led to an increased likelihood of discharge home, reduced need for residential aged care, and improved functional independence, and it actually optimised medical and rehab treatment and facilitated effective discharge planning. So if we implement early, we can actually predict complications and side effects from treatment. We can actually reduce those serious side effects from treatment, giving optimal care. We can actually predict functional decline, estimating survival, assist in treatment decisions. We can actually detect problems a little bit earlier to try and implement other interventions or multidisciplinary team members. We can identify new problems during follow-up, improve mental health and well-being, and have better pain control, and the other benefits as mentioned, as in that early discharge home, increased discharged home, and reduced need for aged care facilities. So really take home, a lot of literature calls it different things. So I think geriatric assessment sometimes can lead to ageism. So some bodies prefer to call it a comprehensive older age assessment, which I think sounds a little bit nicer. Or it can be geriatric evaluation, management and treatment. It's a little bit of a mouthful really, but it uses that word geriatric, which I think implies old to a lot of people out there. So I kind of prefer the comprehensive older age assessment personally. You can see what you think yourselves. Ageism remains an under-recognised and extremely detrimental aspect in cancer care. Just because someone's older than the age of 80, we still treat patients into the 90s if they are fit enough, and that's where that assessment comes into play. We cannot be discriminating patients because of their age. Ageism should not be a thing. Ageism does lead to lower rates of cancer screening and decreased interventions and systemic therapy prescriptions, so poorer survivorship in cancer patients who are older. ASCO, so the American Society of Clinical Oncology, actually calls anyone over the age of 65 as elderly and should have a systemic therapy based on their assessment. Older age assessment information can be used to improve patient outcomes, and actually a lot of areas in the literature are using a nurse-led comprehensive geriatric assessment, a model, and it's been implemented in tertiary hospitals. So don't know what your thinking is there, but I think we can actually do it very well because we are nurses and we have that holistic assessment skills, and we do look at everything and not just physical, functional, but psychosocial, spiritual. We do cover all aspects. And there is some other training. The COSA has a geriatric oncology group, so that's the Clinical Oncology Society of Australia, which if anyone's a CNSA member, which you should be, you can have dual membership. And then the VCC, so the Victorian Cancer Care Cooperative Alliance, runs a cancer and the older person. And excellent resources out there, and some really good Australian research and leading the way for systemic geriatric or comprehensive older age assessment to be implemented within the Australian Cancer Plan. Alright guys, thank you. Any questions, comments, feedback, please email me or catch me in the corridor or here at the Martyr, phone me on 50171. Thank you. So there we go.